Test, test, test. It's now on, so we can hear you, okay?
Are we starting straight away? Ollie, wait for our task. People like to take their seats, please. So welcome everybody to our annual general meeting for 25-26. Whether you're joining us at East Surrey or online, welcome everybody. My name's Jane Phoenix. I'm usually the Deputy Chair of the Trust. At the moment I'm the acting interim chair covering for Anita, our chair who's unwell at the moment. For those of us joining online, just to let you know that there may be some technology issues that you might experience. If that happens, please make sure that we're going to upload a recording of this. So if you do have any problems at all, you can reconnect, or you can actually watch it again tomorrow. Similarly, if there's any particular problems with feedback or anything, if anyone here can let us know, and we'll try and make sure we haven't got phones next to it that will interfere. So over the next hour or so, we're going to be actually reflecting on our last year. We're going to hear some things about some of the highlights of what we've done, some of the things that we're planning to do next. We're also going to be hearing from some of our clinical and services to actually give us some examples of some of the things we've done, including some digital things and some changes to patient care and some of the successes that we've had in a bit more detail. After that, we're also going to have the annual accounts, and we will then have some question time as well. And in that question time, you'll have a chance to actually raise your hand, ask questions, and actually there'll be a panel of people from the Trust, which will be facilitated by Anushka, one of our directors. I should also mention, if you are online, you may get a slight delay of about a minute or so, or up to a minute of feedback. So it might look slightly clunky at times, but hopefully that won't be happening. So with no further ado, I'm going to introduce Andrew, our Chief Exec, and you are going to take us through the first part.
Thank you, Jane. Welcome to all of you, to patients, to residents, to partners in the system, and to the many staff I can see in the audience as well. So thank you so much for spending time this evening with us. I'm Andrew Hines, I'm Chief Executive, and this is my first Sash AGM, so it's a real pleasure for me personally to be here. Obviously, I'd want to pay tribute to my predecessor, Angela Stevenson, and clearly we have split the year between us in terms of our accountability as accountable officer for trust performance. So Angela retired from the organisation back in August, and I joined in September. Can I thank Jane for stepping in as chair very recently and filling the gap with Anita being poorly at the moment, and Jane for your support to me as chief executive over the last couple of months. So what I'll do is just take you through some of the headlines and highlights from the last year. Starting off with the year in numbers. We are a busy trust and we're getting busier, and some of the numbers on the screen I think quite hard to relate to on a day-to-day basis. I prefer to think of it in terms of what an average day at Sash looks like. So the numbers on the screen, for example, mean that on the average day we deliver 10 newborn babies, and we see 340 patients through our emergency department as attendances, just to give you a bit of a sense of what a day in the life looks like. But we continue to be a very busy organisation serving population across East Surrey, Crawley and Horsham, with 5,500 staff and, really importantly, 300 volunteers who support us through all aspects of the work that we do. Next slide. We have got a lot of highlights to draw out, and what I'm going to do is just run through our 5 top-level strategic objectives as a way of just classifying and sort of structuring the year. So if I start off with delivering safe healthcare, a number of headlines, but probably one of the most recent was when we were nationally recognised as one of the top 10 most improved trusts over the last 12 months for our elective performance, which resulted in an invitation to Downing Street for me and a letter from the Prime Minister. So it was a real privilege for us as an organisation to be highlighted in that way. But not limited to planned care, we also saw big improvements through our improvement activities around our hospital-acquired pressure ulcers. We've seen continuing embedding of our model around frailty and reducing overnight stays, which is really important in terms of improving our outcomes for patients with frail conditions. And we've continued to work on our length of stay as one of the key areas that we need to tackle to reduce pressure on our services, but also critically length of stay improvements are associated with reduced risk and improved outcomes for our patients. We also made improvements, big and small, in terms of our outpatient pharmacy and dealing with some of the long-standing challenges around pharmacy with a partnership with Boots, which is now working much better for our patients. But I think it wouldn't be remiss of me not to recognise that we continue to be challenged, not just in the winter, but all year round, with pressures around patient flow, with what that means in terms of patients receiving care in corridors and in temporary escalation spaces, which is absolutely not what we want to be doing in terms of providing the right care at the right time in the right place for our patients. And it's something we're absolutely committed to addressing and to improving. But that was certainly something that was an ongoing theme through the year. Next slide. One of the key national initiatives to improve access to patients is around community diagnostic centres. And we've got a well-established CDC or Community Diagnostic Centre at Crawley. And as you can see on the screen, has been very busy since it was first instigated back in 2023 with over 300,000 tests and investigations. Really excitingly, we were able to replicate that with a new CDC opening in Redhill in the first part of 2026. And we had an official opening attended by one of the ministers within the Department of Health and Social Care. And that is offering a state-of-the-art facility for a range of tests and diagnostic investigations in a location that is really convenient for our patients, where they can be treated, but also get a coffee and do their shopping in the Belfry Shopping Centre. So really good for the local health economy, the local economy, as well as for healthcare. And that means in turn that fewer patients need to attend for services here at the Surrey Hospital site, reducing congestion on this site and avoiding unnecessary journeys. We also have a continuing focus on maternity services, which have been very much in the national spotlight over the last month or so, with a series of investigations and reviews of maternity services in a variety of locations, and a recent national review that has pulled out some of the themes. We are in the process at the moment of reviewing those reviews ourselves to see what we can learn and how we can continue to strengthen our maternity and neonatal services. But even without those national reports, we've been making really good progress over the last couple of years in the actions we've been taking. And one of the key measures of that is our clinical negligence scheme for trusts accreditation, and we've got a further year of full compliance with that as one of the key benchmarks for the services that we provide. And a particular commendation around the approach to tackling health inequalities in newborn screening, which is really important in terms of recognising the diversity of the population that we serve and the need to respond to that. Alongside that, continued good progress and good delivery in terms of our cancer weights, more to do to sustain that, but a year of good delivery and really good performance in our endoscopy services, again, looking at some of the accreditation requirements for that service. I would also just pull out under health outcomes the importance of digital as one of the key enablers to continuing to transform services. And examples of that will be around picture archiving and communications, ensuring that we've got timely access to imaging for all of our clinicians and patients, and work on our digital referral scheme to improve discharge for patients with complex needs. Also thinking about enablers to improvement, it would be remiss if I didn't call out the importance of the Sash charity and also the East Surrey League of Friends in terms of the support that they provide, large and small, to the services that the organisation provides. and also our homegrown approach to improvement, Sash Plus, which brings a consistent methodology and training and philosophy to how we drive improvements, again, large and small, across services in the organisation, both clinical and non-clinical. Of course, we can't do any of that without a really committed, well-trained workforce. And one of our objectives is to be a great place to work for our staff. And we don't always get it right. And therefore, it's really important that we continue to make the improvements that we need to deliver that for our staff. And some of the things that we've put in place over the last 12 months in response very much to staff feedback, to staff survey data and other measures are a Freedom to Speak Up Guardian service, which gives staff 24/7 access to an independent voice in terms of raising concerns. We're the first in the country, we believe, to offer a citizens' advice service on site for our staff. And we continue to focus on our staff recognition. And EDI, equality, diversity and inclusion, is something that we know we've got work to do on, and that's a particular area of focus for us in the new financial year as to how we can better support and value staff with a variety of different protected characteristics. Next slide. Again, all of that is fine, but much of this will require working with partners, and clearly what patients expect of us is that we are working in a seamless way with our partners, whether that's community services, mental health, primary care, voluntary sector, and pretty much anything we're looking to do, whether it's emergency care, whether it's planned care, does require a really close working relationship with partners. A couple of examples of that are around our discharge arrangements, the home first discharge model, which is designed to get patients within the Surrey system who have more complex needs, more rapid access to care packages by a closer working relationship with social care and community and nursing home partners. And that's delivering real benefits, and we need to take that further and ensure that the same benefits are extended to our Sussex community. We've also worked in partnership nationally with the Department of Health and Social Care around our SDEC model. That's same-day emergency care. And that's all about ensuring that patients who don't need an overnight stay in the hospital receive the right multidisciplinary input and intervention through the SDEC service and are enabled to be discharged on the same day. And that reduces the pressure on our beds and reserves them for patients who really do need that overnight stay. So I'll finish by looking forward. That's hopefully a bit of a whistle-stop tour of the last 12 months. But if I think about the year we are now in and looking forward, we have a medium-term strategy which remains committed to a vision that we've had in place for a number of years. And that vision is not lacking ambition. It's to pursue perfection in the delivery of safe, high-quality healthcare, which puts the people of our communities first. We have a set of values that we remain absolutely committed to and hold ourselves to account for in terms of how we behave to ourselves and to our patients. And our 5 core strategic objectives of delivering safe healthcare, being a great place to work, being a valued partner, improving health outcomes, and being financially sustainable are all objectives that we are maintaining our commitment to in this year and beyond. So finally, on my final slide before I pass over to the next speaker, I was going to, if it appears on the screen, pull out a few of the headlines from the year we are already in. We are now 4 months into the current financial year and therefore making good progress against the plans that we set ourselves for this year. Really excitingly for the organisation, the construction of an urgent treatment centre is an absolute commitment. We are going through the final approval stages in terms of the final business case, the full business case, and we've started enabling works on the site. And that will be really transformative in terms of the experience that patients attending the trust for unplanned care will receive going forward. That will be supported by continued improvements to the existing service offerings. So the expansion of our same-day emergency care is a really important part of how we will improve care for patients coming through ED. We have done a lot of work on safe staffing and nursing establishments. An example of that is in the emergency department, where we've put a significant investment into our nursing workforce. And what that means for patients is relying on more permanent staff, less reliance on temporary staff, and that means continuity of care and staff who are committed to the organisation for the long term as part of the ED team. We've also invested significantly in the support we provide for patients presenting with a combination of mental and physical health needs. And the enhanced therapeutic observation and care team will be a real step change, I think, for the care that our patients receive when they present with mental health needs alongside their physical needs. And then finally, we are taking our obligations and commitments and responsibilities seriously around sustainability and green planning. And the eagle-eyed among you will have spotted some of our 3,000 solar panels on the roofs of our hospital, and we hope to go further with that in terms of our green plan. And then finally, we have put in place some further strengthening of leadership arrangements within the organisation so we can sustain and take those improvements forward. And I'm really pleased to welcome to their first AGM today Sarah Burton as our new Chief Nurse, sitting at the back, and Alex Stamp as our Chief Operating Officer. So two really key appointments to the organisation, with a further addition with a new Director of Estates and Facilities who joins us in August. So I hope that's a good, helpful summary of both the year that's passed, but also where we are looking forward. What I'll do now is pass over to the first of 2 or 3 presentations from our clinical and non-clinical colleagues, giving you a flavour on some of the specific areas that we are looking to deliver improvements. So I'll pass over to Oz and Kat to talk about elective and planned care.
Thank you. Thank you very much, Andrew. I'm Oz, I'm Deputy Divisional Director for Surgery and one of the General Management team.
I'm Kat, I'm the Deputy Chief of Surgery.
And we're just here to give you a little bit of a flavour of some of the improvements that the surgical division have done through the year and contributed to obviously a lot of the improvements that Andrew has mentioned. So we just wanted to say really that performance improvement was not driven by a single intervention. It is a lot of teamwork throughout the year, and there's a number of things that the team in surgery and also the wider organisation has helped facilitate to achieve the outcomes that we will talk about. But we wanted to bring to life some of those items, but to touch on really working together and supporting some of our important developments across the trust, such as the community diagnostic centres, where we've really tried to drive one-stop patient care, reduce unnecessary attendances, and really kind of work in line with the vision of the 10-year plan and make that care closer to patients. And also introduced a number of processes and governance that really gave us better visibility of our patients. It allowed us to identify much better those patients that needed more quicker and urgent care, to allow us to focus on those, but also then to make sure that we target our resources as best as possible. Next slide, please. Just to touch on some of the numbers that we talked about and how we've achieved this. Earlier, Andrew gave us a bit of an overview of the trust activity. Just wanted to add in terms of the surgical division here as well, specifically, that we've provided over 218,000 outpatient appointments and over 32,000 elective surgical procedures and managed over 13,000 of the emergency admissions. But also some of the things that then we've done over and above the normal expected activity that contributed to that elective recovery performance from 55 to 66%, which was one of the best improvement in the country. We've reduced the waiting list by over 7,000 patients. That's really important. These are patients waiting for care, and through the actions that we've undertaken, that's come down significantly, but also delivered some extra activity supported by NHS England and the national teams, and we can see that there are over 1,800 patients. Again, patients that would have been waiting much longer for their care, that contributed to additional income through the trust. But also working with our partners. So we have partners that help us deliver our activity, and through that we've delivered over £2 million worth of that activity. And again, bringing down waiting times and delivering care much quicker to patients. Thank you. Next slide, please. There's Kat.
Thank you. So what drove us with these improvements, really? What are the drivers? So there's amazing commitment within the surgical team and the trust as a whole in developing robust elective pathways. We're ring fencing the elective pathways, so we don't cancel cases. So in 25, 26, we saw 0 elective cancellations due to lack of beds. In the past, we had a lot of cancellations, especially winter pressures. That's phenomenal. And for the region, that was really good. We were proactive, and we had some excellent results. We also strengthened our grip on the governance and oversight of elective care in order to reduce delays and treat patients more appropriately, getting the right patients at the right time in order that there's no waste in the system. We also pioneered and adopted quite passionately the use of PIFU. You might have heard of that. It's patient-initiated follow-ups. And in one of our specialties, that's orthopedic, we have shown active take-up of this by patients in order that they are taking control of their health, which is phenomenal, from 1.2% to up to 22%, which is really excellent. We also want, as Andrew mentioned, we want this to be an excellent place for our staff to work. And that's not just looking after their well-being and a great infrastructure, but also having really high-end, innovative work. And one of the classic examples is the use of robotic surgery in urology. We know, and there's so much evidence to show that, when you have robotic surgery with nurse-led, highly specialized nurse-led recovery, the outcome for patients is phenomenal. We got one robot at the moment, and I'm sure as a trust we are keen and we will obtain more, because we want this to be a place where the future surgeons and future nurses and future research, dare I say it, is happening, and we're at the forefront of patient care. Next slide, please.
Thank you very much, Kat. As I said, this is just a small selection of some of the things that our teams have managed to deliver. But one that we really wanted to bring to light, and again in cooperation with our digital colleagues, was supporting the development and enablement of some digital pathways. And the particular example here that we wanted to share with you was a referral system for our patients with learning difficulties. Now, those patients, when they require surgical interventions or even a diagnostic, these are some of our most vulnerable patients, and the coordination and the support that's required to make these things happen is very difficult and very challenging. And through the support of our digital team, we've managed to create a pathway that's very clear and very efficient, that allows us to support these vulnerable patients in as much timely way as possible. And that was a huge win where some of these patients waited a significant time for their care. And also, in terms of optimal utilisation of our capacity, we've worked really hard in developing efficient pathways where we've been able to utilise and make sure that we have our resources deployed in the right places and our patients going to the right places, making sure that we get it right first time and we don't have wasted capacity where possible, knowing that every appointment is valuable. The next thing that we wanted to highlight is outpatient transformation, again, where we've worked with our partners and to try and deliver care closer to patients. We've developed one-stop pathways and spearheaded that through urology and ENT, where we've delivered a significant amount of activity through the Crawley CDC, and really looking forward to the coming years to expand that and deliver that even further into much wider specialties. But that's meant that patients attend less appointments and are treated faster and quicker. And just last but not least, all of these things together have allowed us to not just, talk about the numbers, the things that we've delivered earlier, but it's that patient-centered care. Everything is about what can we do as best as we can for our patients to make sure they receive the care they need as quick as possible and as high quality as possible, aligned with our objectives trust-wide. So it's just a few things that we wanted to really bring to light and make real. But it's just a very, very small selection of the things that have been delivered through the year. Thank you very much, everyone. Thank you.
Hi, I'm Sam Clewitt. I'm the Head of Research, and it's great to be here today to talk to you about the research that goes on at the hospital and give you a flavour of what we do. I'm joined by my colleague Sarah.
Okay. Hi, I'm Sarah. I'm a Senior Research Coordinator here at East Surrey.
Great. So, why does research matter? Well, the evidence is out there that hospitals that do research deliver better care. It improves patient outcomes. So the evidence is there, and this hospital does that and delivers that. It gives patients access to new treatments they might not otherwise have. And it also supports staff development and innovation. It helps us retain our staff and makes the trust a great place to work. Next slide, please. So this is the research team. If those of you have never seen any of us, we wear these lovely blue tops, which was based on patient feedback, participant feedback, that they didn't know who we were, so we made it more visible across the team. We're made up of research nurses, coordinators, assistants, and a governance team as well. And we've also got members of the pharmacy team and the pathology team that support research at the Trust. So, research activity at Sash last year, what did we say we'd do? Well, we said that we'd keep a nice portfolio of studies across a range of specialities. We'd recruit about 5,000 participants, and we'd increase the amount of commercial studies we do. And this is important because we're not funded by the Trust. We're funded externally by the National Institute for Health Research via the Research Delivery Network. So we have to achieve these targets and these goals, or else we lose funding. So we opened 22 new studies last year, but we continue to support a number of studies that we had open. So our staff are supporting 60 studies. We recruited over 5,600 participants. Those include staff as well. We have a range of study types, clinical trials, so full-on drug trials, to observational questionnaire-type studies. We doubled the number of commercial studies we opened. We did 2 the year before. We did 5 last year, so that's great. And we consistently met our timelines for reporting. So we achieved our targets that we said we'd do. Next slide, please. I'm going to hand over to Sarah to talk about some of our studies.
Thank you, Sam. So one of the areas that I manage here in the Trust is women's and children's health. So I just wanted to touch on some of the few studies we've been working on this year. OBS UK has been a fantastic study. It's basically been a service change study, which has really involved many different areas of the Trust. So obstetricians, midwives, MSWs, ODPs, the anaesthetists. It's been a really great collaborative study, but essentially what it's been doing over the last 36 months, the last 9 months in particular, has been embedding a new care bundle for the management of heavy bleeding during and after childbirth. Really fantastic study that I'm really pleased we've been able to deliver here. As part of that, it also included, one of the main significant things it included, is a point of care test as well to help identify women at most risk of who may bleed and who might need a different blood product to support with the management of that in pregnancy. So then Sonobreach is a really great study that our research midwives here in the Trust have been delivering. It's a device study. It's a small handheld scan equipment that connects to a tablet, and basically we've trained midwives in being able to detect whether baby's head's down or not, which is obviously going to really help with our delivering of the babies. We don't want to be having an undiagnosed breech where possible. So if we can be scanning women, doing an additional scan at 36 weeks of pregnancy and identifying his baby in a good position for labour, that's fantastic. And so we're doing that, and we've been recruiting. We've recruited 250 women so far to that trial, which is really great. The feedback's been amazing from this study. And essentially what we hope in the future is this is going to be rolled out in community settings. So you can imagine these handheld pieces of equipment can be out in homes and GP practices, and it just gives women and their partners a reassurance as well as confidence to our team that baby's in a good position for labour and how we can best manage their delivery. The PANDA trial has been a really good study this year as well. It's really looking at the preventing anemia from happening in the first place. So it's a preventative trial, and we're offering women oral iron to check whether this actually prevents anemia from developing later in pregnancy. 70% of pregnancies actually end up with women having anemia that needs treating. So if we can be preventing this and giving oral iron in early pregnancy, then that would be amazing. So that's just some of the maternity studies we've been doing this year. Next slide, please. Thank you. And just a few other things I've been involved in with the teams here. I've actually just come straight from recruiting 2 patients to the FEAST trial, which is the one at the top here. This is a really great innovative study where it's offering a different type of feeding tube that has probes within the catheter that stimulates the back of the throat for patients who have had swallowing difficulties post-stroke, and it's designed to speed up recovery, basically, get them home quicker, improve their swallowing is the ultimate outcome here. So The team is actually led by the speech and language therapy team, which I'm really pleased to say. Obviously, we support them, but it's actually led by our speech and language department, and they've done a fantastic job with it. Our target was only 8 patients, and as of today, because of the 2 new ones, we've just recruited 17. So they didn't just stop at their target; they've continued providing this really great service and trial to patients that need it. So that's the FEAST trial. And just the bottom one here, I just wanted to highlight was, or is an ongoing trial, sorry, which is PSC is a rare, uncurable bile duct disease, and often these patients have comorbid IBD as well. But these patients are particularly at risk of developing liver cancer and maybe needing a liver transplant. So this trial is actually looking at whether giving aspirin can prevent these poor outcomes. And something as simple, widely known as aspirin, is widely available. The safety profile is well known. This could be really significant. So I just wanted to highlight something like this, that actually it's a known drug already. It doesn't need to be a new fancy one that we're looking at. This could be really significant for the outcomes of these patients. And just to finish on that last slide quickly, I just wanted to highlight Dr. Chakrabarti. We couldn't do the research we do here without our clinical colleagues. She is one of our fantastic principal investigators in this trust. She embeds clinical research in her clinical care and makes time outside of routine clinics to see these patients to make sure they get research and the trials that are available to them. So I just wanted to quickly shout out to her as well. So thank you. Back to Sam.
Yeah, speaking of embedding in our teams and working with our clinical colleagues, there's a dermatology team who are an excellent example of having research embedded in all that they do. So Dr. Cliff leads the team. And last year they had a commercial study where they got the first UK recruit. It was a global study. So that's a really great achievement. And the patients on that study are really doing well. So that's great. So it's really embedded in their team. That research is very important, and it attracts staff and it maintains staff and gives us high caliber staff to the department. Next slide, please. And cardiology as well. I just wanted to touch on them as well because we've got Dr. Chuk Chan in the pacing team who leads, a consultant, leading the pacing work that we do at the Trust. And his studies that he was supporting last year, British and Protect, they've been running a few years, but they reached their targets. And he's great at leading his team, and he's passionate about research. So I just wanted to highlight that. And he's pictured here, not with the British study, but with a new study, a commercial study we opened this year called SEPTA, and they've recruited to that as well. So it's a great example of teamwork there as well. Next slide, please. Also, as well, about supporting our staff and encouraging others to do things. And it's not all about consultants doing work. We've got one of our very own staff, Sam Weller, who's a senior research nurse working on oncology studies. She's principal investigator for 2 breast cancer oncology studies. So they're looking at adherence to hormone therapy, 2 different types of studies. One's a randomized study to get some intervention or normal care. And she's just got a quote there about how she's proud and how hopefully this research will lead to improvements in patient-empowered side effect management. So that's great to see. Next slide, please. So looking forwards, what's the year going to be like for us? Well, we aim to meet the government's new timelines for our majority of our studies. So there's a new 150-day timeline. So we're working on that. We're looking good at the moment. We aim to maintain or increase the number of commercial studies we do. I think that will be possible. Keep a nice diverse portfolio of studies, working with our colleagues across the Trust in all the speciality areas, and prioritise studies and ways of working that meet the government's main objectives and the Trust's, so the move to digitalisation, working with the community, our CDCs, using AI for digitalisation and prevention as well. So thank you. I think that's it. Thank you.
So I'm Ben Emney, I'm the Chief Digital and Transformation Officer. And I just want to introduce Emma and Carol, who did one of the larger scale changes that we did last year. We've heard from surgery already about some of the changes that we did, the high impact for a small number of patients. But the story they're going to tell you is about our hospital out of hours, which had an impact on our staff and our patients in a way that has been a challenge. Carol's talked to me about hospital out of hours for many years. So I'm going to hand over to them to tell you the story.
Hello, thanks, Ben. Broadly, the job of a doctor is split into 2 bits. In hours, they cover their wards, go to their clinics, go to theatre, do the procedure list. But then there's the out-of-hours work, and that's anywhere from evenings, weekends, bank holidays, and night shifts. And clearly, there is not all the work that is finished during the day shifts. There is a handover. Handovers are notoriously clinically risky times, and so we have to get it right. Now, for many years, we operated with a kind of flying by the seat of your pants rule. At the weekends, things went really well. We had a database that we used. It was quite clunky, and it wasn't good from an informational governance or from a clinical governance point of view because it didn't link into the patient record. Often, jobs didn't get done, didn't get completed, but we had no idea which did and which didn't. For the out of hours at night work and the evening work, it was scrappy bits of paper. Now, obviously, this is not good. The way and that's for scheduled tasks. For non-scheduled tasks, that involves bleeping. Now, I was a senior registrar here for the last 2 years of my registrar life. I can tell you that the bleep system at that point was awful. I would go to sleep and have PTSD, hearing bleeps still at night. So it's really bad, and it really impacts badly on our junior doctors to have that level of burnout and kind of emotional pulling away from the take. So clearly something had to change. Initially, the previous chief of medicine and I sat down and audited what we did out of hours, who did what, how many calls there were, who were the busiest people. And we launched a hospital at night system that improved the support that we gave and pulled all of the teams clinically that worked out of hours under one umbrella, including the clinical outreach team, the clinical site managers and actual site managers, as well as all of the clinicians that worked at the weekends and out of hours. Now, this was great. It worked really well at improving culture and the support that everybody got. However, it didn't reduce the number of bleeps and, more importantly, didn't improve the number of calls out for support that we had. And so something had to change. And as Ben said, I've been a bug on his doorstep for many years trying to improve matters. But in the meantime, the Trust has been on an enormous IT journey, transforming what we've been doing. But finally, with a little bit of external pressure and with the current Chief of Medicine, we were able to progress things. And then I met Emma.
And that's where I came in. As per our Sash improvement methodology that Andrew touched on earlier on, the first thing that I did, obviously I know a little bit about these workflows. I'm a nurse by background, so I have bleeped the doctors overnight, I've taken messages for them, etc. But I want to know exactly what was happening, what stage we were at this time. So I went and shadowed our resident doctors on nights, on weekends, and looked what they actually did. And what we found is it's not just about bleeps, it's not just about weekend tasks, it's about everything together. So we found that on handover tasks, a lot of our doctors were going home late because of the amount that they had to hand over, bits of paper with very, very limited sort of patient demographics on there as well. We also found the bleeps as well. So the bleep was our main issue that we found. And some of our resident doctors were telling me, and I saw this in practice, that they were getting, in one respect, 75 bleeps per hour. And that is an absolutely enormous amount of bleeps there. And if you think about that isn't including during their break times, including their times with their patients if they're doing clinical procedures or sort of clinical discussions with patients and relatives, how difficult that is to be able to concentrate, and say the cognitive overload on that is absolutely huge. And also bringing in their weekend tasks as well, that's on a secondary system, not attached to our patient record as well, which brings information about, it's not always up to date, we've not got the correct information there. And so you can see we've got a bit of we need to change, we needed to bring something in, we needed to be linked to our patient record, and also things we to reduce the bleeps that we were having, and also improving the weekend tasks, and also improving our handover so that our resident doctors could go home on time and increase patient safety. Next slide, please. So what did we do? So what we did is we took Carol's initial vision of what she'd like and made a very, very simple workflow. But then what we did is that we brought every single stakeholder in a room to talk about what they wanted. So we're looking at site team, our critical care outreach team, our ward nurses, our resident doctors, everyone together. And we also went out to our resident doctors forums as well and got sort of 40 or 50 of them in the room and went through what was important to them, took them through the workflow and got them to actually generate the ideas to be able to help design the workflow itself. Now, they come up with about 50 ideas, fantastic things. And actually, we then got together ourselves and went through them, and every single one of those ideas made it into the workflow. So not only can, when they went live with this workflow, they could see the impact that they had on it as well. So they owned it more, which was really, really important for us. Next slide, please. So what we'd also realised is that training on this was going to be really, really important. We've got lots and lots of different cohorts of staff, our ward nurses, our resident doctors. which have very, very different priorities at nights and weekends. From a nurse, my importance is my patient that's sat in front of me, their pain, what they're experiencing, where our resident doctors are looking at a cohort of patients all the way throughout the hospital, and their importance is, well, who's the priority? Who is more poorly? Who's more sick that I need to see first? So that was really important, that not only did we train the digital workflow, is that we're actually trying to build that culture so that everybody understood each other's role. So we got them all together and we actually trained the nurses and the doctors together, which is the first time we've really done that within digital and digital training, so that they could understand each other's role and break down again those professional barriers so that we understood the culture, and it really, really improved that culture going forward. And then we went live as a digital team. When we go live, we like to go out in numbers. So lots and lots of people in Burgundy were out at night, at the weekend, for a period of about 2 to 3 weeks to make sure everybody had the at-the-elbow support as we went forward. Next slide, please. So then, obviously, again, with our improvement methodology, we went back out and measured the initial impact. Now, this was important to feedback to our deanery as well. And we found that 82-88% of staff actually saw a reduction in bleeps. They saw a reduction in their interrupted breaks and their periods of time they were spending with their patients. And actually, looking at the amount of time it took to actually find out more about our patients, more about what was wrong with the patients, the discussions they were having, actually the actual workflow of bleeping back a ward and getting the nurse they wanted to talk to back to the phone, we measured that and we found that it saved 11.7 clinical hours per night. And that's basically one doctor a shift. So this is not a financial saving. This is a releasing that time back for our doctors to care. And our nurses as well. I mean, our nurses spend a lot of time bleeping doctors that may not answer, bleep again, and then bleeping again, and it's important for them. So we're saving that time to release back to care. And as of now, we've done, I think, probably nearly 100,000 tasks. Now, if we go back to when we look at our current state, our range of bleeps per task were around 1 to 5. So if we average that out about 2 or 3, that equates to around 200,000 bleeps saved in this period from last year. And again, it's got some really, really good long-term benefits as well. So I'm going to pass you back to Carol to talk about that.
Next slide, please. So I can't tell you how much of a transformation this project has been for our clinical workforce. The nurses are deliriously happy about it because they're able to put a job onto the system. I'd just like to add that these are non-urgent or semi-urgent jobs. All of the urgent jobs, so deteriorating patients or medical emergencies, are still communicated to the doctors by bleep. But for these semi and non-urgent jobs, it means that the doctors can go through the list, work out what's more important, and do them in order, relatively speaking. The nurses love it because they've literally handed over the responsibility for that job to the doctor, and then they can walk away and get on with their clinical life. And so they love it as well. Of course, that's only going to be the case if we actually keep on doing the jobs that the nurses put on, which is the thing that we have to make sure we do. From a clinical governance point of view, all of these jobs are tracked. So if a job was put on by a nurse can say, look, here's the job, I put it on here, I've told you it needs to be done in this time, and then we can go back and see whether it was done in that time and if there were any reasons why it wasn't done in that time. So the possibilities for looking at problems in workflow and clinical decision-making are enormous, and they have been great. The really nice thing is that the workload for the whole division that uses this, which at the moment is mainly surgery of all varieties and medicine, is that the clinical site managers can see a top tier on a dashboard of how many jobs are still left to do, how many have been done, and potentially where the trouble spots in the hospital are. If, for example, there's one ward that's putting out 16 jobs and they're still all being done, you've got to ask the question, is the problem with the ward or is the problem with the doctor that's supposed to be covering that ward? And so the site managers can sidle down there and see how they're getting on. It's particularly important for overnight when we don't always have the most senior nurses supporting the wards. We now know that bleeps are mainly, although there's been a bit of mission creep, for really important jobs. And so if they get a bleep, they answer the bleep and there's no debating about it. Whereas before, you might wait for a couple of minutes before you've finished your job before getting back to the inquirer. And mostly importantly, we have lots and lots of lovely data. I can tell you that for the medical team, over a weekend, there is on average between midnight on Saturday and 8 o'clock on Monday morning, on average 450 non and semi-urgent jobs put on for scheduled care over the weekend. That obviously doesn't include the urgent jobs and the emergencies that happen. I can tell you who goes to see them, how long they take, what the jobs are for in terms of prescriptions, what are missing and what the nurses are asking the doctors to prescribe. This is so valuable because it means that we can address the training of both the nurses and the doctors. In terms of bugs, we are getting a little bit of mission creep, as Emma said, about a different interpretation of what urgent means. And so sometimes it might be considered that a particular drug, for example, a statin, might be considered by the nurse to be urgent because she's got a patient in front who said, I'm missing my statin, I want my statin. They'll put that down as it should be done within 1 hour. And the doctors will look at it and think, I don't think that's a 1 hour job. And so there's a little bit of difference in opinion, but all the jobs get done. But the most important thing that we found is that within medicine, the system's worked really well because we've had myself and Dr. Breamhead that have been championing it, and constant comms from me every week, encouraging people to use it and telling them that really there's no option because I'll chase them if they don't. Some of the other departments involved haven't been quite as supportive, and so that's our next task, is to get in touch with those departments and find champions within the department to make sure that they push it forward, because it is an incredibly helpful system. Finally, when we find bugs, we need to fix them, and that's our next task, trying to find a window of time when we can fix them. But thank you for listening.
Good afternoon, everybody. Good to be here. My name is Dave Cooper. I'm the Interim Chief Finance Officer. So I'm going to talk to you a little bit today about our use of financial resources over the last financial year, which you'll also find more detail in the annual report, and then a little bit about what's happening this financial year, including our investment through our capital programme. So this is the 25-26 financial performance at the end of March 2026. As I say, lots of detail in the annual report and accounts that you'll be able to find through our website. So a really challenged start to our financial year. As Andrew mentioned earlier, some of those operational challenges around the number of patients in our hospitals and how we care for those in the best way that we can also has an effect on the amount of resources that then we need to deploy to keep those patients safe. And some of that was unplanned, and we found ourselves sort of off of our original plan. What I'm really proud of what happened, though, is the response to that position, and we developed what we called a financial recovery plan to bring ourselves back into where we'd like to be in terms of our use of resources. And that was a plan that we developed across the organisation with clinicians of all sorts and input from across our divisions as well as our non-clinical teams. And we worked with our partners across what was the Surrey system, so community partners, our commissioners, to provide sort of oversight and support to delivery of that plan over the financial year. And what's really positive is we managed to set out a series of interventions to improve that position, improve those use of resources, and we were able to deliver those as we stated with our partners. So whilst the end of year position was slightly different to the plan at the beginning of the year, by working with our partners, we were able to balance that across the system such that the Surrey system was in financial balance by the end of the year. And getting there, we managed to deliver 25 million of efficiencies through our programme, and then through that financial recovery plan that we started towards the end of the financial year, there were an additional £8 million worth of mitigations that we delivered to get to that year-end position. So our capital investment is then a slightly separate funding route. So this is the money that we can put towards longer-term investments, so things like our buildings, the upkeep of the estate, our clinical equipment, and things like our digital investments too. And we were funded for just under £28 million last financial year, and really proud that we were able to develop a programme and spend to that funding pretty much to the penny. So new nuclear medicine kit, IT infrastructure to support against cyber security. We touched on the CDC, the community diagnostic centre at Red Hill earlier, and again that was funded through our capital programme, and those solar panels that you see on the roof creating energy, green energy here at East Surrey, again, all part of that capital investment for assets that will be here, supporting patient care and supporting the infrastructure over a number of years. Next slide, please. This is just to say that through those annual accounts that you'll find in the annual report, and the headline numbers that we've been through, they're all checked by our external auditors, so external financial company, and we've received an unmodified opinion. So that really just says that those numbers that you can see in the annual accounts and the annual reports can be relied upon, and they've been tested externally. They also do an exercise around value for money, so looking at how we've deployed our resources, how that compares to others, how that compares to the regulations that we work to, and again found a really quite a positive picture there, with one area that we're working on to improve, which is around how we manage our risks across the organisation, and therefore kind of that use of resources, mitigating risks wherever possible. So finally, just a forward look to this coming financial year. So on the left-hand side is our sort of day-to-day revenue financial position, so how we use those resources for delivery of clinical care in particular. And really proud to say that we've developed a plan for this financial year that will see ourselves in a break-even position. So the amount of funding coming in the door for the organisation equal to the expenditure we expect to deploy over the year. And that's for the first time in a number of years that we've managed to, as a single organisation, get to that break-even position. In previous years, it's had to be reliant upon external support to get there. But to do that, it's really challenging. There's this piece down the bottom, which is our efficiency programme. So that's equal to about 6.5% of our total funding for the year. And what that is a series of projects, again, developed with support from our clinicians and our managers across the organisation, that look at how do we improve the services that we're offering. And in doing so, how do we then improve the use of resources and how we deploy those across the organisation. There's a whole range of projects going on to improve on the money, and that will help deliver the savings target and therefore that break-even position as well. On the capital side of things, we've actually had further investment this financial year. We've managed to attract two particularly sizable projects with national funding. So over and above the 30 million we spent last financial year, our capital programme for this year is just over £40 million, with some really exciting projects, including the Urgent Treatment Centre, as well as new theatres for our surgical teams. So lots happening this financial year. And I think I'm ready to pass over to Jane.
Can I ask our panel to join us on the stage, please?
Thank you. So now it's your time. So I'm going to ask everyone to, in fact, no, that's for you, that microphone. I've got a miniature one. So I'm going to ask everyone to just introduce themselves, but there are some other people that are also in the audience. So if we have got some questions that others can be brought in for, so we can facilitate that too. So can we start with yourself, Sarah? Do you want to introduce yourself?
Hello there. Good morning. Oh, good morning. Good evening, everyone. I'm Sarah Burton. I'm the chief nurse here. It's really lovely to see you all.
Hello, everyone. I'm Ed Chetty. I'm the chief medical officer.
Hello again, Andrew Hines, Chief Executive.
Also, hello again, Jane Phoenix, Interim Acting Chair.
Alex Stamp, Chief Operating Officer.
Dave Cooper, Chief Finance Officer.
Hello, everyone. I'm Zara Erie. I'm the Deputy Chief of People and Culture.
Okay, so do we have any questions? Got Parita on hand to come out to you. If not, I can kick us off. We have actually had a couple of questions that have come in. So we'll start with those, and that might just get your juices flowing. So the first question that we've had from a local resident
who has read the quality account and has said the quality account report shows just over half of ED patients are seen within 4 hours, which has not improved from the last year. So that's 16,000 people waiting over 12 hours in ED. If I come to East Surrey next winter with suspected pneumonia, what will actually be different?
Well, so I think it's fair to say I think we all recognise that's a level of access to ED that I don't think we would consider acceptable. And we all do also need to reflect it's indicative of a wider national issue in terms of position. In terms of East Surrey, there's a very active programme of work going on about transforming our front door to UEC. Andrew's touched on some of the investments we've made. So obviously we've got the UTC, which is coming through as a really exciting development. We've got the SDEC work that's already underway, and I think is already starting to have a real impact. We've got support from national teams. So we've got the Getting It Right First Time team who are doing some really active work with our ED team about looking at triage at the front door and how we can expedite that process for patients. And then we're doing a lot of work in terms of our flow through the site and actually looking at our processes with regards to discharge, how we can support patients in terms of their journey through the UEC pathway. I think it's fair to say we've still got work to do. I think we're on a journey with it. And equally, I think we are very clear and firm in our commitment that we should be eradicating corridor care, and I think that's a really important ambition for us. And even today, we had a discharge focused day, getting us right for the summer, and actually had a really good engagement support from a number of teams across the organisation to really focus on that flow through the organisation. It was great to see teams pulling together. So yes, I think work to do, but I think we've got a lot of building blocks in place to get us into a better position next winter.
Thank you. Anything that anyone else wants to add on that? Okay. Any questions? Thank you. Parita's just going to come with the roving microphone, and that's so that the people on screen can hear you.
Understood. Hello, I'm Carol. I'm an acute medical consultant. So building on that question, I wonder whether it would be possible to talk a little bit more about how we're mitigating for the number of wards that had to be shut in the purple zone? Whichever zone it is, whichever colour zone it is, magenta zone, where we've lost 3 and about to lose another 4th ward. Obviously, there is mitigation. It'd be nice to know what it is.
Thank you. So yes, it's. I must admit, I've been struck by the impact of the bed closures that I've had in terms of the flow through the hospital. I think in terms of mitigation, we're looking at a range of options with partners in terms of different models of care and how we can deliver care differently. There are a number of partner organisations who have different models that we could look at seeking to support with. I'm not going to sit here and say it's not going to be challenging, because actually I think we all know that winter can be challenging. I think the key thing, if you look at the national picture, is actually about how we can do things differently. There's a lot of internal work I think we could also do to improve and optimise our length of stay for patients. There are delays in terms of our processes that actually can deliver bed day savings for patients, which is actually the currency that we're operating in. But I think we all recognise the existing model and straining it, and there needs to be change in terms of that, in terms of how we mitigate that and how we deal with that going into winter. I think is going to be a key thing. And actually, partners are really keen to engage with us and support with that. I think there's a lot of support and recognition for the challenges we have and how we can work through that. But I'd say there's still more to do in terms of winter, and I'm not going to sit here and say it's not something that wouldn't be of a concern for us as we go through.
Yeah, I guess while we're kind of referring to winter here, we know that pressures are all year round, and the heat wave itself recently generates additional ambulance conveyances and additional demand. So it's about ensuring 24/7, 12 months a year, we've got the right capacity in place to match demand. I think we've made good progress with reinvesting the resources from the IRU ward, which we closed in March, in the expansion of our same-day emergency care, and that was a very deliberate reinvestment of that budget in a different model of care, and that's still in the process of fully realising the benefits that were intended. But as that continues, we expect that to have a very significant effect in terms of mitigating beds. Clearly, we'll need to continue to balance risk in terms of how we approach capacity in the magenta zone. And what's really critical is we keep the Surrey Fire and Rescue Service on board in terms of giving them assurance that we are compliant with fire regulations in relation to that building. So in some ways it's a kind of catalyst for what is being described nationally in terms of the left shift, ensuring that patients being treated on this site, that the patients that really needs to be treated here that can't be better managed in the community or through prevention. And I think what it's doing is giving us, I think, an incentive to do things that all hospitals across the NHS are working to try to achieve.
Thank you. Any other questions in the room? I have one other question that has been sent in again from our local resident, and this one's about culture. I worry about frontline staff and the reports of the physical violence and verbal abuse which is so present in our world today. Well over half the staff who faced discrimination said that race was a factor, which is a sorry situation for our country. What is the board doing when the abuse is in the hospital?
Thank you. Really good question. The board takes this extremely seriously. I mean, no staff should actually come to work with the expectation that they would experience abuse, discrimination, or violence. And so through its leaders, some of the work that we've been doing, we have strengthened our approach in terms of introducing a new violence and aggression policy last year. And also we have done some additional work by making sure that through that policy, we're making it clear that the trust has a no tolerance approach when it comes to violence and aggression. And you can see that visibly through our posters, signage that is around, also through the screensavers that we have in waiting rooms, etc. I think in addition to that, we're also monitoring the reporting of incidents, staff feedback. We all receive those in-phase notifications when they come through if staff have experienced any violence and aggression. And through that, we're holding ourselves accountable, to make sure that we're not just only looking at the data, but we're looking for trends. We're also looking at what are the improvements we can make. It is a journey. There is still a lot of work for us to do. But in doing so, we've also reestablished, and a number of you would have seen that through our action plan for the staff survey results this year. We've reestablished the Violence and Aggression Working Group, where we're expecting to see more improvements being made through this process. So what I'll say to that is, there is that commitment. We remain committed to making sure that every single staff member coming into work and working here at Sash feels supported, respected, and valued.
Thank you. Is there anything else to add on that? Okay. All right. Any other questions in the room? Yes. Greta.
I'm Adam from the research team. I read I'm quite a recent joiner. I read the green plan because I'm sort of very environmentally interested in. I think there's a lot of really fantastic stuff in there. I think the solar panels and everything. I think the trust's been very proactive with things. As has sort of come to a head quite recently, though, the trust can do a lot of good things in terms of increasing its own sustainability and reducing its carbon output, but there's also an element of the resilience to the changing climate in the here and now. And I think pretty fairly obvious where the questions go, but elements such as like air conditioning and keeping the patients and the staff comfortable. We've been monitoring we're not clinical, so it doesn't matter quite as much, but we've been monitoring the temperatures in our offices, and we hit 34 degrees in the heat wave before last. So, which at that point you're starting to lose productive working hours because you can't think. So I was wondering what if the trust had plans sort of in the shorter and the medium term to counteract the increasing challenges that come with climate change.
Thank you. A very timely question, I think.
Yeah, thank you for the question, and quite right. And the heat that we've experienced over the last month is not just uncomfortable for folk trying their best at work, but it can also have an impact on the care that we provide. And I think everyone's pretty clear they don't want to see me in my shorts every week. So how do we get those that environment better for patients, for staff, for visitors when you're coming in to see loved ones too? So as you rightly said, we've got a green plan, and a lot of that is about reducing our direct emissions and also talking and working with our stakeholders around our, what we call our indirect emissions. But another really important part is our climate adaptation plan. So that is an element I think that we need to do a bit more work on. But our cooling and sort of ventilation of our environments is something that we are much more advanced within that space. So we have improved some of the ventilation across the organisation, and we've invested quite a lot in our what we call the kind of chilling capacity. So that's a sort of central piece of infrastructure. The bit that we've now got in our capital programme, so part of that 43 million pounds worth of investment over the next year, which will be for future years, so probably for next summer, is how you get that cool air right around the organisation and into those places that at the moment aren't getting the right temperatures. So we've got a differentiation across this site, for example, and that investment will help us get cooler air and better conditions to people right across the site.
Happy with that? Thank you. Okay, any other? Oh, sorry, Sarah.
Thank you. I mean, it's a really important question, and I think we mustn't underestimate how difficult it's been for staff working in the extreme heat. And I think there probably is something about the here and now, and post the incident, we had a debrief about what can we put in terms of immediate plans. We do have some areas in our organisation that are air conditioned, and we need to be more robust about how we can make sure that staff can use those areas when we have been experiencing these hot temperatures. And just to add, we were able to mobilise teams of staff to actually do additional water rounds for hydration of the for patients during the heat, and more regular turning, because obviously in the heat on those plastic mattresses, their susceptibility to skin damage is much greater. So we had teams roving the wards to help make sure that that patients were as comfortable as possible, and talking to relatives to assure them. So there are some immediate actions that we've been able to take, while the longer term plans that Dave was just describing are being worked up. Yeah, but thank you for speaking on behalf of the staff. It's been super hot, so thank you.
Thank you. Any other questions? Okay, well, if you do think of questions this evening, and also to those who are on screen, if you do want to follow up with anything, do please email the Sash Communications email and we'll follow up with you. So this isn't your only opportunity. But I think that will be the end of our panel session. Thank you very much.